This is my client Diane, who has spinal stenosis verified by MRI, and most of her symptoms are low back and in the sacroiliac region and down into the buttock. And those symptoms increase as she bends forward, and so it's just sitting here on the table. If I have her bend forward too far, those symptoms are reproduced. Okay? Now I looked at her in prone line, and I'll reproduce that. I'll have her lie on her stomach shortly. Tested all pelvic landmarks and tested passive motion, throughout the pelvis. And the only place we find a restriction is on the left lower quadrant of the sacrum. And so the PSISs are right here. So if I draw a line across, we're at S2. And so S1 is right above that. And I can use my thumb and I can do an impulse. Okay, and we see that the body moves. That force goes through the sacroiliac joint and goes through to the rest of her body. And now if we come down to the lower sacrum, her left side is prominent, meaning it's towards me. And when I do a thrust on the right side, you can see her body move. That force is not blocked. But when I try and induce motion on the left side, there is a lack of motion. Okay, now this is just a quick impulse. Most of the time I take up the slack first and then I create a forward impulse. But because she's sitting, she has weight bearing through that joint. Essentially the slack is already taken up, so all I need to do is do a brief impulse to evaluate the motion. And so it's important when looking for a sacral torsion, which is a rotation about an oblique axis. So the axis is a left axis that goes through both joints. And it begins on the top on the left. It's important to look for that inflection because oftentimes it will not be apparent in standing. It will not be apparent with backward bending. And I'll show you that in prone line it's not present and that there is spring mobility in prone. So go ahead and lie on your stomach. And so PSISs are right here. And so there's the transverse axis. And lower sacrum is right here. We're at about S4, S5 there. It's no longer prominent. And I can use my thumb and I can induce movement through that structure and I can see the whole pelvis move. So the motion is no longer blocked. So the point I'm trying to make is that it's important when looking at a sacral torsion that you look at it in sitting, in addition to looking at it in prone or standing or backward bending, you certainly need to look at it in sitting. And my experience has been that sacral torsions always enhance in sitting flexion. And that's all I need to say about sacral torsion screening. There is a 42-page chapter I wrote in Dalton's book called Dynamic Body, and it has 147 references. And so for a deeper inquiry, I refer you to that book, but the purpose of this brief example was to show the spring testing and to show the spring testing done in sitting and to show that the findings in sitting with Diane were different than the findings in prone. Thank you very much.